Thanks, John. Um, if I wasn't nervous enough, these are really hard acts to follow in the morning. So I'll just put that out there. It's beautiful. Yeah, and thanks to the conference committee for inviting me to present today. I've been at these conferences kind of sporadically over the last decade, so it's really exciting, and I'm really honored to be giving a keynote presentation this year. And what a conference it's been so far. It's been incredible. I'd also just like to acknowledge and thank my team at the Sydney Health Literacy Lab and the Wiser Healthcare Collaboration in Sydney. In particular, Dr. Tessa Kopp, whose work I will be presenting quite a bit of today. She really helped shape and lead kind of this idea as well. And I have no conflicts of interest to disclose. Now, I just want to start by asking you to please just take a moment and read the words that I'm about to put up on the screen, and really think about how these words make you feel. So if you'd asked me a few years ago, I probably would have said empowered, and that as a woman, I had control over my own health and autonomy over my own body. I probably would have thought that I was being advocated for and provided and presented with good information. However, I now think a little bit differently, and throughout the course of my presentation, I will tell you why. So the women's health movement emerged in the 1960s and 1970s alongside the feminist liberation movement, which was also known as the second wave of feminism. And what they advocated for was greater reproductive rights, less medicalization of pregnancy, and more egalitarian care. And they really wanted to emphasize the importance of information to share in decisions about women's healthcare and greater autonomy over women's bodies. And this really did lead to radical gains in knowledge about women's bodies and in overall improvements in women's health. However, that feminist narrative has been increasingly co-opted or hijacked by commercial entities. Industry, consumer and advocacy groups, and media organizations now promote technology, drugs, or interventions to more women than are likely to benefit. Oftentimes, these things are not backed by evidence. They overstate the benefits and underplay the harms, and they use persuasive messaging to do so. And this really increases the risk of harm through inappropriate medicalization, overdiagnosis, and overtreatment. Now, for the rest of my presentation, I'm going to go through a few historical examples and two current examples of where commercial entities have done this. Starting with breast cancer screening. So in the 1930s, the use of the war against breast cancer rhetoric began. And in the decades to follow, slogans such as "Fight Like a Girl" were adopted by media and breast cancer facilities, alongside industry interest and community, charity influence. And this language really, again, promoted the benefits without discussing the harms, using language such as "mammography saves lives," and one of them may be yours. And these are still widely used, as I'm sure most of you know today. They also used messaging to evoke fear, guilt, and place blame on women. For example, in the 1980s, the American Cancer Society, there's an ad there that I'm sure, again, many of you have seen before, saying, if you haven't had your mammogram, you need more than your breasts examined. Some countries now have financial incentives to increase screening, really jeopardizing informed consent, so in the way that the benefits and harms are provided to women. In 1966, a US gynecologist who received funding from companies making hormone replacement therapy published a book called Feminine Forever, arguing that menopause was a disease and HRT was safe and the cure to maintaining femininity. Although this was strongly opposed by some feminists, other health activists embraced the view that HRT was key to women's liberation through enabling greater control over their bodies. And I'm not sure how well you can read that there, but this is the cover of the book, and it's written by a male. And it says, "A fully documented discussion of one of medicine's most revolutionary breakthroughs, the discovery that menopause is a hormone deficiency disease, curable and totally preventable, and that every woman, no matter what her age, can have a fully sex life for her entire life." Now, flibanserin, commonly known also as Addyi, or the female libido pill or female Viagra, about a decade ago, a group called Even the Score really campaigned for approval of this to the FDA, despite limited evidence showing substantial side effects and minimal benefit to women. And their campaign was really backed by this idea that this addressed the unmet needs of women and that several medications for men, and men, and in terms of male sexual dysfunction exist. And this apparently grassroots campaign received funding from the pharmaceutical company who owned the drug. Now, a more recent example are menstrual tracking apps, which detect reproductive conditions. So these apps use pre-diagnostic tools, and they diagnose reproductive conditions, for example, polycystic ovary syndrome. And what they do is they promise empowerment to women using the apps through knowledge and control over their own bodies, despite limited evidence of accuracy and benefit of these tools. Elective egg freezing is another more recent example. So IVF clinic advertising and media campaigns now promote elective egg freezing as enhanced autonomy and justice to women, without really providing adequate information about the likely outcomes and risks, and also as a way to improve gender equality, despite having low success rates and being accessible to only a minority of the population due to costs. Companies also now subsidize egg freezing for their employees in the name of female empowerment, really ignoring the social reasons that prevent women from having children when they're biologically better able. Now I'll highlight a few current examples. The first being breast density notification. So apologies to those who were in my parallel session. There's a few recycled slides here, but basically breast density is an independent risk factor for breast cancer. So it's one of many, many risk factors for breast cancer. And it lowers the sensitivity of mammography. So that means that women who have higher amounts of this dense breast tissue in their breasts, it makes it harder for a tumor to be seen on a mammogram image. So it kind of hides or masks the tumor. And that increases the rate of interval cancers being diagnosed in these women. It's estimated that about 40 to 50% of women in the breast screening population, so women aged 40 to 74 years, have dense breasts. And more frequent mammograms or having supplemental screening, so having a mammogram, then having an ultrasound, or having a mammogram, then having an MRI, is now being recommended to women with dense breasts, so that large kind of cohort of women. And this is because it finds more cancers in these women. However, the long-term outcomes are currently unknown. So the long-term outcomes in terms of mortality and morbidity benefit from breast cancer are unknown. There's no good evidence for that. But what we do know is that it increased false positives and the risks of overdiagnosis and overtreatment in these women. Now, the U.S. federal legislation has now mandates breast density notification after over a decade of advocacy, largely driven by industry interest in community advocacy groups, consumer advocacy groups, not by evidence. There was no evidence to inform this decision, and now every state is now legally has to tell women after every breast screen what her breast density is. However, given that evidence, there are some people still in the field that continue to debate the pros and cons of widespread breast density notification, so telling all these asymptomatic women their breast density. And countries outside the US are really currently contemplating what to do about this, given the growing consumer pressure and the big industry interest in the topic. Some national recommendations acknowledge the lack of evidence in the area. So for example, the draft recommendation statement from the U.S. Preventative Service Task Force that came out a few months ago, and our Breast Screen Australia, which is a national breast screening program in Australia, do acknowledge that there is limited evidence, and we maybe shouldn't be telling women or telling them what to do in terms of supplemental screening. However, the European Society for Breast Imaging does not do this. They put out a statement about a year ago, and what the statement says is that they recommend MRI every 2 to 4 years in women aged 50 to 70 who have dense breasts, and it urges radiological societies and policymakers to act on this now. So our group conducted a systematic review a few years ago looking at the impact of breast density notification on women. So all of these studies were basically out of the US over the last decade when this was kind of being rolled out, and they were all cross-sectional surveys studies. However, what we found is that in these studies, approximately 60% reported some level of anxiety or concern amongst the women. And this was largely driven by misunderstanding of the information. So women were confused. They thought they had breast cancer, not just a risk factor for breast cancer. And they were also confused about what to do with the information in terms of their clinical pathways. And overall, women had very high intentions to pursue supplemental screening, so getting additional ultrasound or MRI. We then conducted an online randomized control trial about a year ago with Australian women So this is a cohort of women who are not currently notified of their breast density and know very little about the topic of breast density. And what we found is that a significantly greater proportion of these women who we notified versus those who didn't and were in the control arm, standard care, were interested in supplemental screening. We're wanting to speak with a doctor, we're anxious, we're confused, and we're worried about breast cancer. So you can see the impact of telling such a large proportion of asymptomatic women may have on the general population if this were to be rolled out nationally or internationally. And this is really what we're up against in terms of the vested interest in this topic and the push from industry and consumers. There's now a National Breast Density Day. Consumer advocacy groups are using kind of rhetoric that was similar to those of early breast screening campaigns, trying to place blame and fear in women, saying don't be dense aware. And I'm not sure how well you can read those, so they're not too bad, but the quotes on the bottom there are from recent media, from academics and clinicians who work in breast cancer. And they're saying things like, I don't think we should wait for guidelines. They could take years. We already have waited too long. We can't keep withholding this information from women. And women need to know the truth. And in knowing the truth, they can become empowered to seek additional screening, even though we don't have any evidence to say that that additional screening would be of any benefit to the woman. And here's a screenshot I did of Dense Breast Info, which is the largest consumer advocacy group around breast density internationally. And you can see all their kind of corporate, what do they call them? Corporate supporters. And every one of those supporters has a vested interest in breast density notification being rolled out in different countries or different jurisdictions, including Volpara Health there. That was my colleague sent me this. They're holding a webinar in Australia next week. And Volpara Health is the largest automated breast density measurement company. They have the technology that measures breast density within mammogram machines internationally. They're the biggest company. And they're got 2 consumers presenting at that, sharing their stories. And they're really trying to, in Australia in particular, what we're seeing is they're really trying to these industries are really trying to build on these consumer stories to push this and push policy in the area. Now, my next example is anti-Müllerian hormone test, or the AMH test. And this is a blood test that indicates the number of eggs left in a woman's ovaries. And it can be helpful in assisted reproduction. So it roughly indicates the amount of oocytes that will be retrieved during an IVF, or during egg freezing. So it guides expectations in those settings. But studies have consistently found that for women outside of fertility clinic settings, so women in the general population, this cannot predict the chances of conceiving, timing to pregnancy, or specific age of menopause. A cohort study that was recently conducted showed that women aged 30 to 44 without infertility issues, those who had normal and low levels of AMH, had the same probability of conceiving after both 6 cycles and 12 cycles. And while AMH is associated with menopause at a population level, predictions can have a broad range. So they range from about 8 to 12 years, and it cannot predict the extremes. So it's really useless as a predictor for any individual woman. And guidelines are now clear about not using this test in women without indication of infertility, saying should not be ordered or used to counsel women who are not infertile about their reproductive status or future fertility potential. However, despite the guidelines and despite the evidence, the AMH test is increasingly promoted to women who haven't even tried to get pregnant. Companies use persuasive feminist rhetoric on upmarket fancy websites and in social media ads to promise empowerment through personalized insights into one's fertility and reproduction. And what they really do is they conceal and gloss over the test limitations. They use different commercial incentives, and they pressure women to be proactive rather than reactive. And you can see a few examples I put up there on the slide. And this example in particular, I particularly like. It says, for too long, women have been dismissed by the healthcare systems. Their bodies too complicated to understand, and their health remains elusive. So we're revolutionizing reproductive healthcare and putting women at the front and center of everything we do. By bringing reproductive science out of the lab and into the hands of every single woman worldwide, we're setting a new standard of scientific rigor and education in female health to nurture the mother of all movements, one powered by a new generation of women who back their bodies and their life choices. And here you can see international examples targeting women in the general population as a future safeguard, so women who are not trying to conceive. So our group conducted a content analysis a few years ago of information on Australian and New Zealand fertility clinic websites. And what we found is that the amount and accuracy of this information varied quite widely. Claims about the utility of the test that were not based on evidence and misleading statements about who the test was suitable for were very common, and 44% of them contain persuasive and misleading statements promoting the test as empowering to women, saying things like information is power and lets you take charge of your own fertility. We then conducted a content analysis of international online companies selling the AMH test direct to consumers. And it included 27 websites across 7 countries, and we found that 74% claimed the test indicated a woman's likelihood of conceiving, and similarly claimed that the test indicated menopause timing. 41% had explicit statements about who the test, that the test could be helpful with family planning or indicate that you need to adjust your reproductive timeline, saying things like, an AMH test may empower a woman to better understand her fertility, allowing her to make informed decisions about conceiving, so should she wish. And 26% use language promoting empowerment and control to push this information, saying things like my body, my data, my choice, and be proactive about your fertility. Now, Tessa led a study last year, a cross-sectional population level survey of the AMH test awareness and usage in Australia. And they found that amongst 2,000 women, 7% of them reported having had the AMH test. And of that, 30% had the test for reasons that were not supported by evidence. So they were just curious about their fertility or thinking about conceiving soon and what their chances may be. So misleading women to believe that this test can reliably predict their fertility can have serious consequences. It can create a false sense of security about delaying pregnancy, and it can also create unwanted anxiety about the ability to conceive. So pressure to freeze eggs, pressure to conceive earlier, and starting IVF when it may not be needed. And previous studies illustrate women's enthusiasm for the test when uninformed about the test limitations. Surprise, surprise. And Australian women, in this study, they concluded that Australian women agree that knowing their ovarian reserve status is a very useful tool in reproductive life planning. And the authors even went on to suggest that there should be AMH screening for every woman around 30 to improve reproductive awareness and enhance chances of parenthood. However, in our group, we conducted an online RCT which compared co-design evidence-based information to the information that was currently online. This was a recent study. And when enabled to make an informed decision, women have less interest in getting the AMH test, less positive attitudes about the test, and greater test knowledge. So ways forward. So these are kind of some big ways forward, and I don't have any answers, but I would like to first start by saying that women's health is just much too important of a topic to let be hijacked by these vested interests, and as are so many other conditions and topics that we've talked about over the course of this conference. So we need greater awareness of the use of feminist language to promote non-evidence-based care, and be wary of the narratives that knowledge is power. We need involvement from a broad range of stakeholders free from vested interests and being more explicit and open about conflicts of interests. We need health professionals and governments to educate and actively counter these commercially driven messages. And like has been discussed before, a pretty broad-ranging way forward, but we do need stronger marketing regulations. We need high-quality clinical trials with continued mandatory reporting of adverse effects or harms once implemented. So this could be the case in breast density notification outside of the US. And without all this, we do really risk creating greater inequalities amongst women. So now I'm just going to end my talk with a story about a woman named Zara. When Zara was 24, she was curious about her fertility. She was not trying to get pregnant. She took the AMH test and was told she had as many eggs as a 39-year-old woman. Zara spent days in bed and for months grieved the family she thought she may never have. Then her and her partner decided to conceive. She recalls, the first month we tried, I fell pregnant. Had I not gotten the test, I'm sure I wouldn't have gotten pregnant that young. She now believes that the test was misleading, as the same thing happened with her second child. She conceived in the first month of trying. And despite thinking the test was misleading and being an quite educated woman, she still worries that she may go into premature menopause. She says, it does just give you this feeling in the back of your mind that there's something wrong, and that's really unfounded. There's no evidence to say that. And everyone needs to have good health information when they're making medical decisions if it's going to give you some information that you can't unknow. So now I'd just like you to look up these words again on the screen. Have your views changed at all? To me, it is easy to see how millions of women like Zara worldwide can be subjected to test treatments or interventions that are not backed by evidence and can have profound impacts on their life. We as a community of health professionals, academics, and citizens need to ensure that the very goals of feminism are not undermined through commercially driven and uninformed use of the feminist discourse promoting non-evidence-based care. Thank you.